Hello, everybody. This is Dr. Matt Pratt-Hyatt with RealTime Laboratories. So thank you, everybody, for joining us for this webinar today. I know this is a very trying time for everybody, but we really appreciate you joining us here. So today we're going to be talking about COVID and testing and treatment. I'm really excited to have Drs. Hooper and Brewer here with me. So let me just introduce everybody here. So I am Dr. Pratt-Hyatt. I am a PhD here in molecular and cellular biology. I'm the Vice President of Development of Business and Products at RealTime. Then I have the founder of RealTime, Dennis Hooper, here. And then also on the line, we have Dr. Joseph Brewer, who is at St. Luke's Hospital in Kansas City, and he is an infectious disease specialist. So today I'll be talking a little bit about the history of COVID, and then Dr. Hooper will talk about the testing, and then Dr. Brewer is going to talk about the treatment. So a little bit reminder for everybody that next Tuesday I'll be doing a webinar on mycotoxins, everywhere from being able to diagnose it in the patient to helping in the home to treatment. So the full gamut, I'll be going across the whole thing next Tuesday. So just a reminder to everybody, there is a sign up for that on the RealTime website. Lastly, we're going to be doing a Q&A at the end of this. I'll be reading the questions, and then I'll have either myself or Dr. Hooper or Dr. Brewer, whoever is best to answer it, will answer that question. So that'll be at the end of the whole, after everybody's presented their slides here. So we'll go through that at the end. Okay, so today, symptoms and history. We'll talk about the types of testing and treatment. So COVID-19, coronaviruses, there's been a lot of history of that. And so like the first one that was really reported that was serious was in 2002, and that was the SARS epidemic, where you had only 8,000 cases in 17 countries and only a little bit over 700 deaths. And then we had MERS in 2012, which was about 8 years ago. Again, about 860 deaths. So now we have the COVID virus, which was first reported in 2019 in China, and it's unfortunately moved across the whole world. There's still a lot of research going on, a lot of genetics that has been done. I've been reading a lot in Nature and Science, looking at the different genetic sequences being done to COVID and how it relates to past coronaviruses and how it's mutated from one version to the next. And what a lot of scientists believe is that at one point in time it's jumped from an animal to humans, and is probably initially being moved around in either bats or pangolins. However, there's a lot of research that shows this jump probably happened like a year to two ago, and then moved around humans not very infectiously, and then there was a mutation sometime in the human population which causes it to become a lot more infectious. And that's what this paper here just was published about 3 weeks ago in Nature Medicine indicates. So they're looking at the genetics of COVID-19. And really, this paragraph here that I highlighted, it says, this scenario presumes a period of unrecognized transmission in humans between the initial zoonotic event and the acquisition of the polybasic cleavage site. So there was a mutation in humans at some point, which made this virus a lot more pathogenic. So this mutation allowed things to be moved from human to human transmission over an extended period. So this is still in theory somewhat. But for this virus, unlike a lot of viruses, this is a virus that has an RNA enclosed protein in the middle of it. So it doesn't have DNA like humans do, and a lot of bacteria you have actually an RNA in the middle of the virus. And then it's got these spike proteins, these red spike proteins on the outside, and then a lipid membrane that keeps the RNA safe. So what are the symptoms? So what patients really should be doing this test? And really, almost anybody should be doing this test, especially because there's a lot of data out there that indicates that 50% of the population is unsymptomatic. So we really need to figure out who are carriers of this disease. But for the people that are really should be running this test are people that have cough, fever, tiredness, difficulty breathing, loss of taste and or smell. All these are common symptoms that are being shown up a lot lately. I just heard somebody talk about today how they were talking to a patient that was using mouthwash and they couldn't taste the mouthwash at all. So this is a very important sign that it could be coronavirus. So COVID-19 prevention tips. I mean, obviously anybody that's listening to this probably knows about this, but just put this at home, avoid contact with sick people, stay home if sick, cough or sneeze into your elbow, disinfect frequently, touch surface. Obviously, we want to make sure that you're using your Lysol, Clorox wipes on door handles, on computer keyboards, anywhere where keypads. I once saw somebody saying they use Q-tips to push the numbers on a keypad, for an ATM or something like that. Wash your hands very often, and high-risk groups should refill prescriptions to avoid large crowds, and definitely don't touch your face. The CDC has just recently changed their prevention tips where they recommend now people, this used to say don't wear a mask, but however that's been recently changed to now they are recommending people to wear a mask. So there's two things that this helps. This helps prevent people from breathing in the virus, and more importantly, it probably prevents people that have touched a surface that's been contaminated. Then they can put it into their mouth, put their hands in their mouth, and then contaminate themselves. So having a mask can help prevent people from putting their hands into their mouth or touching their face. Okay, so our next part of our seminar today is that we're going to have Dr. Dennis Hooper here, who is an MD, PhD, and he's the founder of RealTime Labs. So he'll be talking about the different types of testing. So bringing in Dr. Hooper.
Thank you, Matt. As you can see in this picture, this isn't me, but this is what we look like when we're working in a laboratory. So for those of you who know me personally, if you work at all or come and see me or anything, we're covered practically from head to tail with some kind of garb, and we really are protecting our staff and ourselves from anything that is in the laboratory. We're going to talk about testing for the COVID-19, which is really a challenge for us understanding what is going on in the US as well as in the world. And that's because it's changing, as you can see by watching the news reports, that it's changing on a daily and even an hourly basis. And it's been changing very quickly since the outbreak that we saw in the US begin in February. There was a test that was developed by CDC that received Food and Drug Administration, or FDA, approval under something we call the Emergency Use Authorization, or EUA. And it was distributed to the public health laboratories in the first few weeks of testing. February 29th, the FDA began allowing hospital and commercial laboratories like RealTime Lab to use their own tests, which is called a laboratory developed test, before the tests undergo FDA review. Just to remind you, FDA is very stringent on looking at tests and looking at their validations, looking at what sensitivity and specificity is, and they are allowing the laboratories to do their own without reviewing the FDA guidelines at the present time. Now, who should be tested. We get that call all the time. I want to be tested now. I don't know if I'm sick, but I want to know if I'm really being tested or should be tested. Well, not everyone needs to be tested for COVID-19. Most people, most of you out there, have mild illness. It's just like influenza and are able to recover at home. Treatment is specifically approved for the virus as it is evolving. Testing results may be helpful to us to inform any of us making decisions about who you come in contact with. I know there's a lot of people, I don't want you to come to my house. I don't want to see you in the grocery store. Stay away from me because you may have something. And that's a decision that you have to make. CDC has guidance for who should be tested, but decisions about testing are at the discretion of the states. And you'll see that when the President's Council meets, and they always refer back to the states because it's a state and local health department issue and the individual clinicians who are making these decisions. Clinicians should work with their state and local health departments, which they are doing, to coordinate the testing through the public health. Now, they want to know, everybody wants to know, well, when do I get my priority for testing? There's a priority that CDC has set, and there are 4 of these, and this was just established again and repeated as of April 5th of this year. The first priority, and as you can see that when you listen to the governor's talk, are hospitalized patients and symptomatic healthcare workers. In other words, the docs, the nurses, the lab people, etc. Then there's a second priority of patients in long-term care facilities with symptoms. Patients who are 65 years of age and older with symptoms. Now that doesn't, I'm over 65, I have no symptoms, so I should not be in the priority of a testing group. Patients with underlying conditions with symptoms. In other words, do you have some kind of respiratory problem? Do you have some kind of illness that is associated with your immune system? And then, of course, the first responders with symptoms. Okay, oh, there's the third group. Where's that? We missed one slide. There it is. The CDC's continued priorities are the third priority, and that's a critical infrastructure workers with symptoms. Individuals who don't meet any of the above categories that are in the hospital, the care centers, the healthcare workers and first responders, the individuals with mild symptoms in communities and experiencing high COVID-19 hospitalizations. So everyone else that fits in this third priority for CDC. And then the non-priority are individuals without symptoms. In other words, if you're sitting at home and you say, oh, I can't go out until I have a test done because I work with old people or I sit around with old people, but you're not sick. You're not going in the hospital. You don't have symptoms. So you're not a priority as CDC sees it. Okay, so now that we decided who's going to get the test, what do we test? No, and there's a lot of discussions about that. At present, all the testing for COVID-19 is only allowed to be conducted with the consultation of a healthcare provider. Now, we believe at RealTime Lab, as well as many other people in the community and in the country, that patients should be looked at by themselves. They should know if they're sick, and this test should be available. Hopefully that will occur, and CDC will see its way to open up that guideline. The guidance below addresses these options for self-collection. So if you're at home and you want to do self-collection, you can do it, but no laboratory should be doing it for you until they get CDC's clearance. The initial diagnostic test for COVID is collect a test on upper respiratory specimens. And the most important one so far is the nasopharyngeal specimen. Some of you have seen that President Trump had one, and he said he took the swab and he put it up as far as you go up the nose, and then you turn right at the eyeball. And that's true. It goes a long way up the nose, and you should use a single polyester swab with a plastic shaft. So if your doctor is using any other kind of swab, say, I don't want that one. When collection of the nasopharyngeal swab, the NP swab, isn't possible, you can just do an anterior nair. That's the front part of your nose. And that's, sometimes you take your kid in or you go in and they swab your nose for a staph infection. And they usually swab it the lower part of your nose and they go up a little bit higher, and it's collected by a healthcare professional or on-site self-collection staff using a collection swab. And these are put in a transport tube containing viral transport media. And I gave the names of these, but you can put it in sterile saline as well. The other one that we're working on right now is sputum, and that can be collected and tested for this COVID-19 as well. But you can't induce it. In other words, you can't use a respirator, you can't use a nebulizer, etc. You should cough it up from as deep as you can. Now, if you're in the hospital, we will accept bronchial alveolar lavages, and that's where they wash the lung out and send that to the laboratory. So the most important one, nasopharyngeal swabs, but CDC has allowed us to accept the nair specimen, and then they will accept a nasal wash as well as a BAL. Now, you got to be careful what swabs you use. Don't just use a swab that you use to clean your ears, because the calcium, do not use calcium alginate, and you don't use wooden shafts, because they have substances that can inactivate the viruses, and they actually inhibit the DNA testing or the RNA testing. And then you place those swabs into the tubes with the viral media, and they're scored, so you can break them off, and you put them in there, twist the cap, and if you can't get them in the mail right away, you can keep them in a refrigerator, which everybody, I don't want to do that, but you can keep it cold and then send it to the laboratory by FedEx or take it to the lab. Most laboratories will not let you bring it to the lab, so you have to mail it. There's a nasal wash as well that can be done, and that is actually squeezing or putting saline up into your nose and letting it drip out into a container. Sputum is collected. It's not called spit. It's not called saliva. You have to cough up some big amount of sputum. Sputum is from your lungs. It's usually thick and sticky, and it comes, saliva comes from your mouth, and it's watery and thin. So we don't want saliva, or you're going to get a negative test possibly. And we provide specific instructions in the kit, as well as other laboratories who have validated this test. So in review, nasopharyngeal swabs, you can do a nair swab, and you can use saliva. The testing is designed to look at, there's a lot of different machines, and they're called platforms. And these platforms are used in many, many different laboratories to look at RSV, all these different viruses that you're used to, influenza virus, etc. We use the Thermo Fisher machines, and they're, again, emergency use authorization, and these have all been approved, and the reagents have been approved. And this is looking for virus. It is not looking for antibody. Why isn't it looking for antibody yet? Because there isn't too many kits out there to evaluate. It's more stable, the DNA is more stable, or the RNA is more stable than anything. The antibodies can be very stable if they're down the road about 2 to 3 weeks, but the RNA is what we're looking for first to see if you're infected. The antibodies remain in you for a long time afterwards. It's like you having antibodies to any other thing that you've had a vaccine for. And there's the biggest problem we have so far is there's limited data available, which indicates that there's a slower than expected response to the COVID-19. With a peak, there's an IgG response, and you're going to hear that all the time in the meetings, that they occur around day 11. And this was just published on 27 March of this year in the Journal of Medical Virology. So, to repeat, antibodies are going to be the wave of the future as far as telling us if we've had the infection. RNA is looking to see, do we have it now? And can we go around and meet our family and friends? So there's the test that does the antibodies is called an ELISA test. The real-time PCR that we do for the RNA doesn't require blood. I've told you it's just a swab. And the PCR has been approved by CDC and the FDA. There has recently been an approval of an ELISA test for COVID-19 in blood. And this is was just published today, in fact. It was published the 3rd of April. It's produced by a company called Cellex in North Carolina. And we are going to be evaluating that with other antibody tests as well. So the viral load shows up much sooner than the antibodies, but the antibodies will show up later in after you got rid of the virus. The testing, here's the swab, and it's just a little swab on a wire loop, or these swabs in viral transport media is present in the kit that we send out. If you have too much mucus in your nose, you got to blow your nose. And that's all there is to it. Don't give me a lot of mucus, or don't give us a lot of mucus. And then you open the kit, you take out the swab, and then you put it in your nose, and then you roll it around in your nose, put it back in the kit, and you break it where there's a little nick in the swab, and then you close it up with the media. And here it is where President Trump is saying it goes all the way up to the eyeball, but that's not what we want to use. I don't want to use those anymore because it looks painful, and it is painful, but you can do the Nair swab. And then you place that into the transport media, and you can send it by FedEx to the laboratory. We provide FedEx. We're currently in the final stages of validating the sputum test, and these have the same turnaround time, and the cost is the same. We can turn things around in, I like to say 24 hours, but our staff here and our management wants to say 48 to 72 hours. That's just in case something happens, but we can turn them around fast and get them out to the laboratory, or from the laboratory to the doctor's office or the hospitals, and hopefully to the patient's houses soon. And this is the platform. So you're going to see, if you want to read more about our platforms, we have patient information and provider information that is present on our website, and you'll see that when you go to our website. And we're going to get Dr. Brewer to talk about the treatment development, of the projected timeline for treatment and prevention. Presently, this was just published in the journal, where is that Forbes. Journal? I can barely see it, in Forbes recently, where there was 7 proposed drugs that they're using, 16 different antibody tests that they're looking at, and 43 vaccines. So they have a big job to do to evaluate this for you and I and all the sick people. So with that, we're going to introduce Dr. Joseph Brewer from Kansas City to talk about the treatment available at the present time, which we all know is a big discussion with the president's group as well.
Yeah, well, I'm gonna unmute Dr. Brewer here. Hey, Dr. Brewer, can you hear me?
I can, Matt. Thank you.
Yeah, well, it's all yours now.
Okay, so firstly, who's Dr. Brewer? I'm a infectious diseases specialist here in Kansas City. I've been in practice for 40 years, have a large experience with many different kinds of infections. I have firsthand experience with this. I rounded on our COVID units in our hospital today, including the ICU, in which we have 4 patients on ventilators. So I have firsthand experience almost every day. Next slide. So I've broken down the treatments into roughly 3 groups. There are probably more than this. There's new treatments, as Dr. Hooper said, there's new data coming out almost hourly, and there's all kinds of different treatment items that are being looked at, and these are coming out very rapidly. But I'm going to try to give you an overview of some of the frontline things that we're working with. So we'll talk about antivirals, antibodies, and then the interleukin-6 inhibition. So back that one up. Okay, so antivirals, we have hydroxychloroquine, which I'm sure anyone who's listened to anything in the media has heard a lot about that. We'll discuss that in some length. Hydroxychloroquine plus azithromycin, remdesivir, anti-HIV medications, and then we'll talk about antibodies and IL-6. Next slide. So let's first talk about, I'm going to go a little bit in reverse order and talk about the one that we're most widely using last. So first of all, remdesivir. Remdesivir is a intravenous antiviral. This was developed by Gilead pharmaceutical company and is originally developed for Ebola. It's what we call a nucleotide analog, and basically it interacts with a polymerase called an RNA-dependent RNA polymerase that allows the virus to grow once it infects a cell, it allows the virus to grow the RNA to a full RNA for making a new virus, and drugs like this that we call nucleotide analogs actually stop the growth of the RNA chain, and the virus cannot make new viruses. It's been shown actually in test tube studies that the remdesivir is effective against a wide array of DNA viruses. Prior to the COVID-19, which is a virus called SARS-CoV-2, there was evidence that this particular drug worked for the original SARS virus, the one that Matt mentioned occurred back in 2002, 2003, and then the MERS-CoV. So there's evidence that this actually should work against the SARS-CoV-2. Currently, it's an investigational. The availability to hospitals, this would be hospitalized patients who are severely ill. So it's through an expanded access program. The preliminary reports suggest that it is successful. We have very preliminary data. There are studies ongoing, and that the safety assessment of, because this drug has never been used this widespread before, so there's ongoing safety assessments that are being evaluated. Next slide. Now, antibodies. You've heard a lot about antibodies in the media, so I'll try to clarify this. So the concept are what we call neutralizing antibodies. So these are antibodies that bind, that are part of the immune system. These are proteins in the immune system that bind to the various parts of the virus. Probably some of the most important ones are the ones that bind to that spike protein that's on the surface, which is where the virus binds to the cell and allows it to infect a cell. So there's basically 2 kinds of antibodies we talk about: passive immunization and active immunization. Passive transfer is when we take pre-made antibodies, either from a patient or made synthetically, and give that to a patient. So you've probably all heard about this convalescent serum. So convalescent serum is taking the plasma actually from an infected patient. So this is someone who's infected, has been infected, recovered, and has developed full immunity. Then one purifies the plasma from that individual, and that has antibodies in it that would ostensibly have activity against the coronavirus, and you would give that to an actively infected patient. Now, this could be given preventatively, but most of the discussion right now is giving it to an actively infected patient to try to boost the immune response and get the virus gone from their system more quickly. The second type of antibodies that can be given passively are monoclonal antibodies. These are antibodies directed against various parts of the virus that are developed synthetically in a laboratory. And there are several companies that are working on this. They're moving along with their studies, and this could be quite exciting as well. This could theoretically be given either as a treatment or prophylaxis or prevention. So passive antibodies of either kind, at least where we stand right now, are probably going to be limited in the number of patients that can be treated and will likely be reserved for the most severe cases. Now, why do we say that? Well, certainly it would take a large number of patients to donate their plasma to give to other individuals who are infected. And then the monoclonal antibodies have to be given by injection, and it will take a while to ramp up production, we would guess. Now, the other aspect of antibodies is active stimulation of one's own antibodies. And this is basically the whole concept of COVID vaccine. So this is now actually not treatment. This is prevention of COVID. And I'm sure most of you are aware there are a number of companies all over the world that are working on a COVID vaccine. These trials are moving along quite quickly, but it's still going to be a while before we have a vaccine, and I don't think we can predict with certainty how long that will take. Next slide. Briefly, I'll move through interleukin-6 inhibitors. Interleukin-6 is a cytokine. And we know now that severe cases of COVID that develop acute lung injury and eventually this ARDS or adult respiratory distress syndrome are associated with this intense inflammation in the lungs, which is often called the cytokine storm. One of the major cytokines, not the only one, but one of the major cytokines involved is this one called interleukin-6 or IL-6. We now know that IL-6 blood levels are elevated in COVID patients. There are a number of inhibitors that are monoclonal antibodies that interact with IL-6 and reduce its pro-inflammatory effects that are induced by the cytokine. Some of these are actually already on the market for other diseases, a variety of different diseases, and a number of these are being repurposed in clinical trials to see if they will work on COVID infection. The trials that we're aware of so far, at least the one that we've looked at our hospital, is a randomized placebo-controlled trial. So part of the patients will get the inhibitor, part of them will get the placebo. This is, again, directed to try to reduce the inflammation and hopefully get people off of ventilators earlier and get them on the road to recovery earlier. The early anecdotal results, obviously we don't have anything back from the trials, but I've heard from some of my infectious disease colleagues around the country that the early anecdotal results do show some promise in patients who have severe illness. This will be restricted almost entirely to patients with severe life-threatening illness. Next slide. Okay, now let's move to the main thing that I want to talk about, which is hydroxychloroquine. So hydroxychloroquine is an old drug. It came on the market in 1955. Its original and still current use is for malaria, and it's used for both the prevention and the treatment of specific kinds of malaria. It's been used worldwide in tens of millions of patients since 1955. In the last couple of decades, if not longer, it's been used for autoimmune conditions with a lot of emphasis on lupus and rheumatoid arthritis. And again, it's been used by millions of patients for both conditions, prevention and treatment of malaria and treatment of autoimmune conditions. The drug has a good safety profile. There are some issues that need to be assessed. There can be eye problems, but that's only with chronic use, and we're using it short term in these patients. There are cardiac rhythm disturbances, which is called long or prolonging the QT interval, which could cause an arrhythmia. Those are fairly uncommon with hydroxychloroquine alone. I'll come back and mention that with the azithromycin combination. And then rarely there can be some mild mental status changes, rash, and so forth. But by and large, this drug has had a good safety profile for over 60 years. Next slide. So what about hydroxychloroquine for COVID? And there's actually a lot more data than people would realize. So we'll run through this quickly. The first of all is the in vitro data. So this is the test tube data about why would we think hydroxychloroquine could work. This was a lot more than just throwing a dart at a dartboard and saying, oh, well, let's just try hydroxychloroquine. That's not what happened at all. It turns out that during the first SARS outbreak in 2002 and 2003, there was a lot of outstanding research that was done. In particular, there was a paper done at CDC in 2005 by Dr. Vincent et al. That showed that chloroquine, which is an older relative of hydroxychloroquine, was extremely potent at preventing the SARS virus. Again, this is the original SARS virus, from infecting cells. If you mixed in the chloroquine with the cells before you tried to infect them with the virus, there was almost 100% prevention of infection at an appropriate concentration, and this was an attainable concentration with human dosing. So then they did the opposite experiment where they infected the cells first and then mixed in the hydroxychloroquine, and they got again, very potent inhibition of the virus. So then how does hydroxychloroquine play into the equation? Well, there was a landmark study done just a few weeks ago, published by a group in China, and they actually looked at both chloroquine and hydroxychloroquine in vitro in the test tube. And they found that both of them could inhibit the new coronavirus, SARS-CoV-2, but even though they both inhibited, hydroxychloroquine was dramatically more potent than chloroquine. So in my mind right now, chloroquine is a past discussion with COVID, and the drug of choice from the antimalarial standpoint would be hydroxychloroquine. Now, studies in humans with hydroxychloroquine alone, there's one small randomized study, you have the reference there on the slide, that was just published recently from China. They actually demonstrated that, and this was a placebo-controlled study. So when you hear there's not been any randomized placebo-controlled studies with hydroxychloroquine, that is incorrect. Was the study small? Yes, but here are the results. So basically, this study demonstrated that hydroxychloroquine led to clinical improvements in the hydroxychloroquine group, basically reduction of fever, cough, and the CT chest scans improved as compared to the controls, and the results were statistically significant. And if you're wondering what small is, there were 31 patients in each group, in the hydroxychloroquine group and in the control group. Next slide. So now what about the newer wave, which is hydroxychloroquine azithromycin combination? Basically, this data comes from France, from a group in Marseille, France. You have the reference there. And the first study that was published roughly 2 weeks ago was an open label treatment of 20 hospitalized COVID patients compared to 16 patients being treated at another facility, but not on any specific therapy for COVID, no antiviral therapy for COVID other than supportive care. the group that did this study felt that it was unethical to have a control group in their hospital. So basically, the study was done as follows. The patients had a daily nasopharyngeal swab done for the SARS-CoV virus, and the predetermined endpoint of the study that was done for analysis was the percent of nasopharyngeal swabs by PCR that were negative on day 6 after the start of treatment. So first of all, the control group. So these were these were 16 patients at the other hospital, and by day 6 of just observing them and doing a swab every day, only 12% had cleared the virus from their nasal pharyngeal swab. Hydroxychloroquine alone was 14 patients, and that was pretty good. 15% of the patients cleared the virus by day 6. But look what happens when hydroxychloroquine is combined with azithromycin. Again, the numbers are small, only 6 patients, but it was 100% were clear of the virus on day 6. And interestingly, in this paper, 5 of the 6 patients had cleared the virus on day 3. So this works very rapidly to clear the virus from the system. Next slide. So this same group from France, from Marseille, France, just published a little over a week ago their second study. And this was basically an extension of the prior study out to 80 hospitalized COVID positive patients. Now, in this particular study, all patients received the hydroxychloroquine azithromycin combination from day 1. So there was clinical improvement were seen in all but 1 patient, and only 1 patient died, and this was an older woman, age 86, who had numerous comorbidities and apparently was quite ill when she first came in. This study also was quite impressive, in which they showed rapid fall in the NP swab viral loads by determining PCR. 83% were negative for the virus on day 7 after starting the treatments, and I'll give you the dosing in a minute, and 93% were negative on day 8. Interestingly, they also did viral cultures. Now, these are not commercially available. These are research testing. And on viral cultures from the nose, this was incredible. On day 5, 97.5% of the patients tested negative by viral culture. So what this suggests is that there may be some RNA that hangs around in the nasal swab, but the virus may actually be gone and not infectious. Now, we do not know that for sure, and we're not telling people who still have a positive nasal swab to go run around and infect a bunch of people, but it is encouraging that it looks like the virus on this combination goes away very quickly. Another interesting part of this was this allowed patients to be rapidly discharged from the hospital. So the mean number of days in the hospital, remember all these patients were hospitalized, and the mean day of discharge from the hospital was 5 days. So the conclusion by the authors of this study is that early treatment with this combination leads to clinical improvement, rapid decrease in viral burden, thus decreased transmission, and early discharge from the hospital. Next slide. Okay, so what about hydroxychloroquine azithromycin combination? It appears to be the best available treatment regimen at present. These drugs have both been on the market a long time. They have a good safety profile, and they're relatively inexpensive, et cetera. Now, how widespread we use these drugs is really based on the supply and availability. It is getting better in the United States. As you probably heard, a number of doses are going into the national stockpile that have been contributed by pharmaceutical companies, other countries, et cetera. And so the supply and availability is getting better, but it's still not perfect. So some of the things that we go by. First is sickest first. And we always go by that. So the people who are sickest, the hospitalized patients, are first in line to get this therapy. We've already talked about that even the combination has a good safety profile. Now, one of the things that we do have to watch for, particularly in hospitalized patients who are more ill, is this QTC prolongation. If you combine these 2 drugs, the QTC interval, which the prolongation could lead to cardiac arrhythmia, does increase a little bit when you have both drugs combined together. So we do monitor EKGs and so forth and watch for that. I've already mentioned that these are relatively inexpensive drugs, and the most interesting thing is there's a growing real-time experience from around the world, multiple physicians, multiple hospitals, multiple countries from all over the world that shows that this looks quite promising. Next slide. So what dosing do we use? I'm not saying this is the dosing everyone uses. I'm telling you this is what dosing we use at our hospital. We use the dosing regimen from the French studies, the 2 French studies that I just mentioned. So their dosing regimen is hydroxychloroquine, 200 milligrams 3 times a day for 10 days. And then in what we've done recently, we just done this in about the past week, is in hospitalized patients to reduce PPE use. Because if you give it 3 times a day, that means the nurse has to take a pill into the room 3 times a day. So to reduce the 3rd trip into the room, we have changed the dosing to 400 milligrams in the morning and 200 milligrams in the evening, such that we can take 1 less trip into the room to administer a dose, which will save on PPE use, mask gowns, and so forth. With regard to the azithromycin, right out of the French trials, they used 500 milligrams on day 1 and then 250 milligrams on day 2 through 5. Now, we have found that we do occasionally need to adjust the dosing for specific situations. More prolonged illness, people on the ventilator, they're continuing to shed the virus. We have gone a bit longer. Obesity appears to be an issue, such that we may be underdosing in people who are significantly obese. And then prolonged QT. I had a patient today that we had to reduce the dose because of prolonged QT. So we do have to be a little creative with the dosing, but the guidelines I've given you there are at least the basics to start with. Next slide. So the other question that we get from many individuals, particularly physicians, nurses, and so forth, is what about prophylaxis? Could you take hydroxychloroquine or the like preventatively? So this is this is a recommendation that came out from India about 2 weeks ago. So this is recommended by the National Task Force for COVID in the country of India. So they recommend the dosing down there, as you can see, malaria dosing. They recommend it for healthcare workers with potential exposure to COVID and to household contacts of a COVID positive case. And the dose is the same dosing that's been used for 60 years for malaria prophylaxis, which is hydroxychloroquine, 400 milligrams. It comes in a 200 milligram size pill, so it's 2 pills once a week. And as I mentioned there, it's the same for malaria prophylaxis. Now, in the data from India, they do suggest 8 weeks of this prophylaxis for healthcare workers and 4 weeks for a household exposure situation. The 4 weeks I understand. I'm not sure I quite understand the 8 weeks, but maybe that's why they're going to do data analysis and see how things are working. I have colleagues of mine who are physicians that practice in the United States now, but are originally from India. They still have friends who practice who are physicians in India, and every single physician they've talked to in India is on this program. But again, it's recommended by their national task force. Whether this works or not, we cannot be sure, but it is a curious development that's occurred in India, and I do know physicians in the United States that are taking this prophylaxis as well. These are frontline physicians who are dealing with COVID patients daily. And I believe that's the last slide.
Thank you so much, Dr. Brewer, that was a lot of great information. So I think let's see what kind of questions we have here. Let's see if you want to answer that one right there. So there was a comment that said, I hear some cases do not respond until 400 milligrams TID.
Could you restate that, Matt?
I hear some cases do not respond until 400 milligrams TID. I assume that's talking about hydroxychloroquine. Well,
I think one has to be careful that kind of dosing. I've probably treated in the range of 40 to 50 patients now, both outpatients and inpatients, and I would not go that high with dosing. I think there's too much risk for QT prolongation. So I'm sticking with the dosing from the French studies. It is rumored that the group from France may be coming out in the next week or so with analysis of 1,000 patients. So I assume that the dosing has remained the same.
Dr. Brewer, there's a question that says, how does Plaquenil work on the virus, and what's the mechanism of action? And then also, how does zithromycin, which a lot of people in this group, or the Z-Pack, does it have antiviral properties? So first of all, if you could comment on.
Sure. Well, so let's take hydroxychloroquine first. Remember, the key to everything, the key to this entire disease, is the binding of that red spike protein that Matt showed you earlier on the surface of the virus to a receptor on epithelial cells in the respiratory tract. So these receptors are called ACE2, angiotensin converting enzyme 2 receptors. And so it is the binding of the virus to those receptors that allows the virus to then infect the cell, reproduce inside of the cell, and then repeat the cycle over and over and over again. It appears as though hydroxychloroquine interrupts that process. Now, there's a number of different mechanisms. There's not just one way it probably does it. There's several different mechanisms by which the virus interrupts that binding, and it prevents the virus from binding to the receptor on the cell, and thus prevents the virus from infecting the cell. As azithromycin, it's a bit more questionable because it has not been studied as much. Remember the original chloroquine studies that were done in 2005, starting in 2004, 2005. We knew the mechanism of how chloroquine worked, and then by extrapolation, hydroxychloroquine, which is a very close cousin of chloroquine. So we knew the mechanisms with chloroquine and hydroxychloroquine clear back for 15 years. Azithromycin obviously has just come on the scene recently. Now there is some data that azithromycin, not erythromycin, but azithromycin may have antiviral properties. There's some very preliminary data that suggest azithromycin might have some effect on that binding affinity of the spike protein for the receptor on the cell. That's very preliminary. Another thing I might mention is the group in France did in vitro testing on the combination of hydroxychloroquine and azithromycin, and in vitro they have shown that they are indeed synergistic. In other words, 1 + 1 = 3.
Thanks, Dr. Brewer. So the next question is, and I'll let Dr. Hooper answer this one. So they say, can we drop ship a kit of potentially infected patients or viral RNA? And if so, how do we do the request and payment?
At the present time, if you recall my list of specific patients, the infected patient would have to be verified by the clinician to have the symptoms that CDC is stating are important, like fever and respiratory problems, etc. So you need to review those CDC criteria. Now, again, I said that we're hoping that in the future that to get rid of this fear and to allow people to come out of their shells a little bit, that this may happen. But at the present time, I'm unfamiliar with any direction the CDC has allowed us to do this with. I'm hoping that that occurs, and I think in the next few days, CDC may change its direction.
Okay, I agree with everything that Dr. Hooper said there. On a more practical note, I would recommend going to the RealTime website, and you can click on a link there to sign if you're not currently a practitioner of ours. There is a link under the COVID-19 page to register as a practitioner. And then if you are a practitioner, you can email kits@realtimelab.com to order kits to either be sent to your office, or if you do have a patient that is in need of a COVID kit sent to their home, you can drop ship kits by emailing the addresses to kits@realtimelab.com.
Again, Matt, you need to be careful though. If you're drop shipping them to the home, who's going to be taking those samples, because they could be taking them incorrectly, and until CDC and NIH or NAID tells us that those procedures that are written are acceptable, I would be extremely cautious of seeing a negative result. A positive result would be okay, but, and Dr. Brewer, if you can comment on that as well.
I would agree.
Dr. Brewer, we have another question here. Do you have any suggestions on any supplements patients should take prior, to try to prevent the cytokine storm or any of the symptoms that might arise from contracting COVID?
I don't personally have any experience. This has been all over the place. There's, as most of you know, there's been a roundabout discussion on even things like non-steroidal anti-inflammatory agents. Is it safe to take, say, Advil, Relieve, or is that going to actually make it worse? Is Tylenol okay? Acetaminophen? So these are this has all been pretty circular and I think inconclusive. The same thing with supplements. I think pretty inconclusive at the present time. I'm not opposed to trying safe supplements that might downregulate inflammation. An interesting one that I've heard recently is there's apparently some data to suggest that zinc might also inhibit the virus from binding. I haven't seen much data on that, but it is being talked about, and there are some physicians that are using zinc in an infected patient, and some of them have been using hydroxychloroquine, azithromycin, and zinc, all three.
Okay, thank you for that. We have another question here, Dr. Brewer. I think that you'll be best at advising this one. We have a practitioner that says, how do you advise as far as outpatient management, such as the QT prolongation?
Yeah, that's very difficult. Generally, we look at their history and look for any, we look at their medication list of what meds they're on and any that might be associated with QT prolongation. And if that is an issue, you can always talk to their pharmacy and have them run through that list. And because pharmacies have programs in their computers that can run through that, and then look through and if they have a history of congestive heart failure or something like that, we would be much more cautious. Most of the patients we treated so far are relatively younger and healthy that have been at outpatients, and it has been an issue. At least with hydroxychloroquine alone, rheumatologists have treated millions of those people without doing EKGs ahead of time.
We're going to do two more questions, and then we'll post the rest of the questions on our website with answers from either myself, Dr. Pratt Hyatt, or you, Dr. Brewer. But one of the questions, can you get reinfected with the virus? Maybe due to significant mutations. I'll let you comment on that first. And then
I can handle that one. So there was studies from China have looked at any heterogeneity of the virus, and I can't remember now, but they looked at several thousand isolates, and there was like a 99.9% relatedness. So at least thus far, what we know from China is that there were not mutations occurring. I think that's quite unlikely. We didn't see that with the original SARS, even though there certainly was a much lower number of cases. But I think at least at the moment, it's pretty unlikely. but the other issue is with reinfection is above and beyond mutation is what's the robustness of the antibody response, because your protection against future infection is how robust was the antibody response. And so there may be some people that don't develop as much of a response as others. So we don't really know. There's some very limited data from China. We don't really know what the reinfection rate will be. I suppose it's just like, somebody with a poor immune system might be able to get flu twice in one season. So I think we have more to learn on that, but I don't think mutation is going to be an issue at the moment.
Well, I think that's it for now. There are many questions, and we appreciate the questions, but time is run out.
Thank you, everybody, for showing up. And remember, next week we have other webinar on mycotoxins. So sign up for that on our webpage. Thanks again, everybody.